Okay, shall we start?
I'm ready.
Okay, great. Excellent then. Um, Dear all, welcome to our new webinar session in NEMUS. We had a short recess after Vancouver, but now we are excited to start a new phase of webinar presentations. We have updated our website as well with new documents and recording. We also were extremely pleased to present our special issue in the International AIDS Conference in Vancouver 2 months ago, or a bit over a month ago. That publication, that special issue on PrEP, is open access, published by the Journal of the International AIDS Society. So you can access it either through our website at NEMUS or through the JAIA's website as well. So we are starting with two webinars. Actually, one is today with Anik Borges, and the second one is in 5 days, this Tuesday, the 8th of September, with Dr. Fabio Mesquita, the director of the National AIDS Program in Brazil, who is going to present the update on PrEP he presented at Vancouver, at the Vancouver conference. But now let's focus on Anik's presentation, and Anik Borges is going to present on the role of PrEP and other individual level interventions in combination HIV prevention among trans women in Peru. Anik is a research associate at Imperial College London, Faculty of Medicine, School of Public Health. Her research is focused on improving and developing mathematical models to estimate the contribution of different sources of risk to HIV incidence in a range of populations and among and settings. She's especially interested in undertaking the HIV epidemic among key populations to better inform prevention programs. She has conducted work focused on the key populations of Latin America, including the development of mathematical models to study the epidemic among prison inmates in Peru and to investigate the potential impact of pre-exposure prophylaxis among MSM and trans women in Lima. Let me just transfer to Anik. So Anik, welcome here, and please go ahead. In fact, just before you start speaking, our webinar will be recorded, so it will be available for other viewers later, and we'll mute everybody to improve the transmission, and people will always be able to use the chat windows to make comments and questions. She will speak, and after she speaks, we'll have a few minutes to address the comments and questions. Thank you very much. Please, Anik, go ahead.
Thank you. Can you see my screen?
Yes.
Great. Should I minimize the GoToMeeting window, or it's fine? Can you also see that?
You don't have to do that, Anik.
Everybody can control that in their own.
Sorry?
Everybody can control that in their own screen.
Okay.
Everybody can control the size, in their own screen.
Okay, perfect. So, thank you very much for the invitation. This is very much work in progress. So these are preliminary results, and we're revising quite a few cost assumptions as well as effectiveness of the intervention assumptions. So comments and advice will be much appreciated. We're presenting this work at ISSTDR as well in a couple of weeks, and there's still time to make a few changes to produce the final results. So that's why we decided to do the presentation today to make the most of your So this study is part of a broader study, and I haven't detailed this in the presentation, but basically the study is looking at developing a state-of-the-art prevention program for MSM and transgender women in Peru. And it consists of three main components. The first component is a stakeholder analysis that was carried out over the past year that looked at perceptions of existing and novel interventions among MSM and trans, and consulted members of the community, of the MSM and trans community, as well as healthcare professionals and decision makers. And the second component was a health system capacity analysis that looked at the current state of the health system, and in particular the HIV care in Peru, and with a particular focus on MSM and transgender women. And the third component is a mathematical model study that looks at the different interventions that were investigated during these two first components that were identified as the most important or likely to be implemented. And the point of this study is to estimate the effectiveness and cost effectiveness of the different intervention packages to reduce HIV incidence among trans women sex workers. So we're doing two specific modeling studies, one that is on trans women sex workers and one that is on MSM and transgender women as a whole in Peru. So this one is specifically focusing on transgender women sex workers in Lima. This is because there was a special need to provide information on prevention for transgender women, and since a very high proportion of transgender women in Lima report sex work, and this provides different means of intervening, we decided to focus on this population. So as I said, this study is grounded on the reality of the health system in Peru based on the health system capacity analysis. So it includes current costs as well as availability of healthcare interventions in Peru. And the starting point for the modeling analysis is a model that we developed for a study that was published last year as part of the issue of on sex work in the Lancet. And it looked at modeling the impact of different interventions among transgender sex workers and their clients and stable partners in Lima. So we have been using this model, but modified it to include other interventions and changes based on new information that we've been accumulating. So I'm going to quickly go through the main model assumptions. I could speak about the assumptions for much longer than this, but we don't have time, but I'm happy to answer any questions at the end of the presentation. But basically, the transgender population in Lima is estimated at 20,000 women. HIV prevalence, according to the most recent study, is 27%. Approximately 70% of transgender women in Lima report engaging in sex work. The percentage of MSM and trans women who receive ART, so of positive, HIV positive trans women who receive ART, is between 25 and 30%. We have no data specific for transgender women, and this is why I'm giving the aggregate data. And even here, there is no specific information either for MSM and trans, but specific local studies have allowed us to estimate this, although there is quite a lot of uncertainty around this number. Condom use with clients is 75% according to last report from studies in Lima. The proportion who have a stable partner, and by stable partner we mean non-commercial partners that they for a period of time higher than 6 months, but it's quite a broad definition because it doesn't necessarily mean a monogamous stable partner. It's just somebody that they see more frequently over a longer period of time. Life expectancy among transgender women was estimated at 60 years based on other Latin American studies. Again, there is no specific information for Peru here. and life expectancy on ART when starting late, so with a CD4 below 200, is assumed to be 25 years. So you can see the sexual mixing patterns in this simple diagram of the model. So on the left and the top, we see transgender women sex workers who are not in a stable relationship, and these mixed with clients only. And we have transgender women in a stable relationship at the bottom, and these mix with clients and with stable partners. And each group is divided in transgender women clients, transgender women in a stable relationship, and stable partners that are either exclusively insertive, exclusively receptive, or versatile. And of course, the distribution of the population in each of these groups is different. So many more transgender women will be exclusively receptive, and many more clients will be exclusively insertive, etc. So the mixing patterns between the populations is based on this. There is also different condom use with clients and with stable partners, and different number of sex acts per partner with these different partner types. Regarding the disease progression and treatment, this is how the model divides or represents the natural history of infection. So with the diagram on the left, you can see that people progress from being susceptible to being acutely infected, latent infection with a CD4 above 500, latent infections with a CD4 between 350 and 500, latent infection for a CD4 between 200 and 350, pre-AIDS, which is CD4 below 200, and finally AIDS. I have quite a... I don't know if somebody's trying to write something, because I'm getting quite a few noises. I hope it's okay. Finally, we have treatment with initial guidelines, which was for a CD4 below 200. And from 2012, the ART guidelines changed in Peru to include people with a CD4 count below 350. So as I said before, the life expectancy on ART at a late entry is 25 years. The reduction in risk of transmission is 85%. It's lower than estimated in HTPTN 052 because there is evidence that there is lower adherence among transgender women from other countries. So we don't have information from Peru, but based on information from San Francisco and other settings that have specific information on transgender, we see that adherence is lower among this population. So we have estimated it would be 85%. Transgender women, we assume that transgender women sex workers, clients, and partners have the same access and adherence to ART, and we assume here that there is no dropout. So this is a simplification of the reality of treatment access. This slide just shows you the model calibration to the epidemic in Lima. So we see on the left at the top the HIV prevalence among transgender women sex workers in Lima. So in red, it's the best fit of the model to the data. The red crosses are data. And we represent uncertainty through all of these other epidemic fits that were selected in the calibration. On the right, we see the ART coverage among HIV-positive transgender women sex workers in Lima, and the cross represents that 25% coverage that is estimated for currently. So the interventions that have been considered in this study are increasing condom use and lubricant with clients, increasing condom use and lubricant with stable partners, scale up of screening and ART coverage in line with the new national guidelines, so that recently changed. So they changed in December to include individuals with a CD4 below 500. We also look at test and offer, so offering ART independently of CD4 count, and this is basically an expansion from the previous intervention. And we also look at PrEP, and finally this assumes that there is a structural intervention implemented to reduce stigma and discrimination as a necessary component to each of these interventions. Just a quick diagram to represent what the analysis does. So basically, we're looking at combination prevention scenarios. We look at the epidemic with no intervention, so the baseline number of new infections through time. In gray, you have the intervention period, which is assumed to be 10 years from 2016 onwards. And then we look at what would happen if we had a condom intervention. And so what would be the reduction in the number of new infections with this intervention? And we also look at what would be the reduction in number of new infections with ART coverage, increased ART coverage that would increase, well, that would imply, of course, increased testing and linkage to care, PrEP, and test and offer. And so these are looking at each intervention individually, and then we also look at each possible combination of interventions. So when we combine these different interventions, we come with 23 possible combinations. And so this is what I'm going to be presenting in terms of results. So the question is, which combination prevention package is more effective among transgender women sex workers in Lima? So just to tell you a little bit more about the interventions, the condom campaign for use with clients assumes that there will be a 15% relative increase in condom use. So not plus 15%, but a relative increase based on the condom use in 2016. And this is assumed to be achieved in 3 years and to remain stable thereafter. So yeah, just to remind you that it's a relative increase, so we look at condom use in 2016 times 1.15. So this is a relatively low increase, but it's given that it's been very difficult to maintain condom use and at current levels, and that actually we see a decrease in condom use, we felt that we couldn't estimate, well, we couldn't assume a higher increase. This is also based on the stakeholder analysis, where we asked experts as well as members of the community what they felt would be the possible increase in condom use following an intervention. With stable partners, we assume this is lower at 10%, given that it's more difficult to achieve increases in condom use with stable partners. And again, it's achieved after 3 years, and it remains stable thereafter. For PrEP, we assume a coverage of 15% of transgender women sex workers. This would be achieved after 5 years. So it increases linearly up to 15% and then stays stable for the 5 years that remain in terms of the intervention. The adherence patterns were based on IPREX results, whereby 50% had a bad adherence and 50% had a good adherence. We're aware that this is that this was a trial where people didn't know whether they were taking or not the treatment, and that this might affect adherence. But there is evidence from the IPREX-OLE that adherence is actually lower among transgender women. So we decided to remain conservative in assumptions regarding PrEP adherence for the baseline analysis. We will carry out further analysis looking at different assumptions with better adherence, assuming better support for transgender women sex workers. And so this results in an effectiveness within the IPREX ranges, which was, well, the midpoint was, well, the point estimate was 44%. So regarding ART scale-up, so the ART intervention following the new guidelines, so CD4 below 500. So this assumes that transgender women sex workers will test every year to 18 months. And it results in an increasing coverage to approximately 60% of HIV-positive trans women sex workers. Again, transmission reduction is assumed to be 85%, and life expectancy on treatment is assumed to be 40 years, and again, no dropout. So you can see in the figure how from 2016 onwards, the coverage increases to about 65%. Oh, I forgot to translate that bit. So again, test and offer. So access to treatment for people with CD4 above 500. So it's an expansion of the previous intervention. So basically, it's treatment for all of those who are diagnosed HIV positive. And with this intervention, the coverage increases to approximately 80% of HIV positive transgender women sex workers. Again, we assume that the transmission reduction is 85%. And life expectancy when treated early is assumed to be 50 years. And again, no dropout. Of course, better access to treatment implies substantial improvements of screening activities. So at the moment, it is estimated that only about a quarter of HIV positive MSM and trans in Peru are aware of their status. So testing rates are incredibly low. And so we can't just assume that by increasing the threshold in CD4 for the treatment guidelines, it will result in an increased coverage of treatment. So all the costs that are implied by increasing testing rates are incorporated in the treatment interventions. So these are, I'm not going to go through the costs in detail, and I didn't have time to translate it to English, but basically the cost of PrEP, including the drug plus the monitoring and of course all of the health professionals and outreach activities, is estimated at about 4,900 nuevos soles per year. So this is quite a high cost, and it's mostly due to the very high cost of Truvada, current actual cost in Peru. The costs of ART, so this includes the cost of ART initiation, the treatment, and of course the monitoring, is estimated at 1,500 nuevos soles per year. And the cost of screening is calculated separately. So as you see, we've included costs of outreach and cost of system strengthening. So this includes linkage, ensuring that there are no logistic problems with ensuring stocks, and improving adherence. So this is basically a program to improve the system, the HIV care system. Cost of condoms, this includes the cost of the condoms, and also takes into account that a proportion of these condoms will be lost during the intervention distribution. It includes a campaign and workshops to improve condom use among transgender women. So I'm now going to present some preliminary results. So this shows the number and proportion of infections averted over 10 years with each combination of interventions. So this looks at the number and proportion of infections averted among all, so not only trans, but also their clients and their partners. And so we can see the 23 different combinations. So each bar corresponds to either one intervention in isolation or a combination of interventions. A corresponds to condom use with clients. B corresponds to condom use with stable partner. C is ART, test and offer. D is PrEP, and E is ART with the new guidelines. And so you can see that the number of infections averted will go from about 500 to potentially over, well, nearly 6,000 new infections over those 10 years, depending on the combination of interventions. We show the results for the best fit, and you can see the error bars, which correspond to the maximum and minimum for the other epidemic scenarios that were included. And so you can see on the right side, same results, but not for number of infections averted, but for proportion of infections averted. So we see that, of course, the more interventions we include, the more infections are averted, and that certain combinations are more effective than others. So I'm also showing here the UNGAS goal, which is averting 50% of new infections over 10 years. And so we see that we require a combination of interventions to actually achieve this goal. So no intervention in isolation actually reaches this goal. I've highlighted 3 interventions just to make the presentation a bit more easy to follow. So these are, in yellow, we have condom use with client and the ART intervention with the new norm. AC in orange corresponds to condom use with client and test and offer. And in red, ADE corresponds to condom use with client, PrEP, and new guidelines, ART. So basically, these are the 3 that either reach the 50% reduction in new infections, or that gets us close to actually averting these 50% new infections. So we will be comparing these 3 combinations of interventions throughout the presentation, just to give a better idea of how the different combinations of interventions compare. Now I'm looking at cost and cost per infections averted for each intervention. So you can see on the left the total cost of each of the interventions. So we see that it goes from, this again is in nuevos soles, so it goes from relatively low costs, so less than 10 million nuevos soles over the period, to nearly 90 million when we combine all of the interventions. And we see a big difference from the moment we start including PrEP into the intervention. So PrEP is D, and you can see that there is an important split, which I'm just showing now with that line. And so basically this is due to the very high cost of Truvada currently in Peru. On the right, I'm presenting costs per infection averted. And so we can see that PrEP in isolation is incredibly expensive, and actually it has quite a high variation range. And other interventions, including condom use, are much cheaper on that scale. So again, I'm presenting the 3 interventions that we looked at in the previous slide. So I'm just reminding you that AE is condom use with client and ART according to the new guidelines. AC, so in orange, is condom use with client and test and offer. And finally, ADE is condom use with clients and ART with new guidelines and PrEP. So we can see that the intervention including PrEP is much more expensive than the 2 others. And when we look at this on the other graph, we can see that there is a synergy between prevention and treatment. So all of the interventions, so C and E combined with AB, which are condom use with either client or stable partner, result in much lower cost per infection averted. We also see that PrEP is much more cost effective in combination with other interventions. So all of those interventions that are highlighted include PrEP, but in combination with other interventions. Again, you can see the 3 different interventions there. So given that the price of Truvada is likely to be reduced in Peru after following negotiations with Gilead, etc., we looked at scenarios with lower cost of PrEP, well, lower cost of Truvada. So these results are exactly the same as above, but they assume that the cost of Truvada is 75% lower than currently. So it's at $30 versus $100 per month. And so we see that now the different interventions are much more comparable in terms of cost, although the interventions, including PrEP, are still more expensive, but the difference is much less pronounced. Finally, we looked at at cost in terms of DALYs to make it more comparable to other interventions and in other studies. So just a reminder of what DALYs are. So they are disability-adjusted life years, and they're a measure of overall disease burden expressed as a cumulative number of years lost due to ill health, disability, or early death. And so basically it's a sum of those years that are lost with a disability and the years of life lost. And so what we've done for this analysis is convert the infections averted into DALYs. The information required to do this is the mean age at infection, the life expectancy on treatment, the life expectancy when HIV-free, and after discounting, we obtained an estimate of 12.7 DALYs per infections averted for transgender women. And so I am presenting now the cost per DALY averted for each intervention. So again, we're comparing Truvada at $120 per month versus $30 per month. And I'm presenting this against thresholds of cost effectiveness to make them a bit more meaningful. However, we don't have a cost effectiveness threshold that is specific for Peru yet. And this is something that we're working on and that we feel is very important, as all these thresholds are a bit subjective and have their limitations. So if we look at the WHO choice threshold with 1 GDP per capita per DALY as the threshold, we see that pretty much all of the interventions are found to be cost effective. The problem with this threshold is that most interventions come out as cost effective because it's quite a generous threshold. Another threshold that has been considered a bit more realistic is the World Bank threshold. And so this considers that an intervention is cost effective if it's under about $1,000 per DALY. And so we see that quite a few of the interventions are below this threshold, and it considers the interventions as very cost effective if they are below about $200 per DALY. And we see that in this scenario, fewer interventions are considered very cost effective. Basically, only the interventions that include condom use and treatment. And so you can see again the yellow, orange, and red interventions. So under the cost effectiveness, very cost effective threshold of the World Bank, only the yellow and the orange interventions are considered cost effective, very cost effective. Under the cost-effective threshold, the intervention including PrEP is also considered cost-effective following World Bank scenarios. When we move to the right and we look at the cost per DALY averted, when assuming a cost of Truvada of $30 per month, we see that that the intervention, including PrEP, is still not very cost effective according to the World Bank, but it gets closer to that threshold. This graph is another way of presenting these results, and it's to give you a better impression of the benefits versus costs. So basically what we're looking at is the total DALYs averted on the y-axis versus the cost of the total cost of the intervention on the x-axis. And so all of the interventions that are in the far left corner provide you more DALYs averted for fewer for lower costs. So basically, we're looking at finding interventions that are in that red corner, and we see again that the yellow and the orange are in this corner, and in the opposite corner, in the gray corner, we see that the interventions, including PrEP, are more costly and result in fewer DALYs averted. Once we look at the lower cost of Truvada, the shape changes slightly, and we see that several of the interventions containing PrEP actually become closer to the left side. but still we see a difference in terms of cost compared to the yellow and orange intervention. So to conclude, to avert 50% of new infections, a minimum expenditure of 11 million new nuevos soles over 10 years would be required. Implemented WHO treatment guidelines combined with increased condom use among transgender women sex workers would achieve this and would be highly cost effective according to World Bank threshold. However, condom use remains problematic, and so this would require strong condom promotion programs. There is a synergy between prevention and treatment, and the results clearly show that there is a need to invest in both to maximize the use of resources. In combination, these interventions are very cost effective according to World Bank threshold, as said previously. Test and offer is a viable intervention among this population. It would allow maintaining diagnosed individuals in care. So what has been seen from data of the treatment program is that once individuals are on treatment, there is the loss to follow up is much lower. So this is not taken into account in the model, as we don't look at treatment dropout, but it's something that should be considered, that treating sooner might ensure that that they are kept in care. PrEP would be a viable intervention among transgender women sex workers who do not use condoms in combination with other interventions, but prices need to drop. And as I said, we have considered low adherence, and we will be doing a further analysis looking at higher adherence, which would be which would be facilitated by better programs that support transgender women when taking PrEP. So a few limitations and next steps. So we need to revise assumptions for the costs of certain components. So this is still preliminary, and I have received quite a few new pieces of information regarding costs. So this is why I'm a note of caution regarding the fact that these results are preliminary. This does not include pre-ART monitoring costs, so this results in an underestimation of the cost of treatment under new guidelines, because I'm not including those costs. So in this sense, the test and offer would become a little bit more a little bit less expensive compared to the new guidelines if I take this into account. So this is something that will be done as well. We need to carry out sensitivity analysis for the transmission reduction in ART because we have assumed that it's 85%, but it might be lower, and we also need to look at the impact of treatment dropout. So these are two simplifications that we've assumed for now regarding the treatment representation that will be improved. And we need to estimate DALYs averted directly from the model. So at the moment, as I showed, I just transform a number of infections averted into DALYs. And this assumes that those who did not get infected during those 10 years will not get infected in the future, which is not necessarily realistic. And it can be avoided by directly using model estimates. So this will be done as well. As I said, we need to identify a cost effectiveness threshold specific to Peru, and we still need to define the structural intervention required to support these interventions and to cost it. So the plan is to carry out an analysis that includes the structural intervention and that does not include a structural intervention, and to compare impact and cost. So this will be a further analysis that still needs to be carried out, but will be done in the next couple of weeks. And so yes, this structural intervention is especially important because intervention access and uptake among these marginalized population requires an improvement in their environment as well as in the healthcare environment. And finally, we need to collect information specific to transgender women. So we need information on life expectancy among transgender women in Lima, ART coverage, retention in care, ART adherence, proportion with undetectable viral load. So all of these is estimated from the the data that we have from MSM and trans, but it's not specific to trans, and we require more disaggregated data, as well as for sexual behavior with different partner types. So there is quite a lot of qualitative studies that provide information on this, but they would need to be complemented by quantitative studies. And that's all for today. Thank you very much for listening, and any questions and comments, welcome.
Thank you, Anik. That's great work, and as Anik is explaining, this is work in progress. This is a study we've been conducting. I'm also part of a team, and definitely the idea was not a focus on PrEP, but a definition of a combination prevention package for Peruvian MSM and trans women. This was a sub-study specifically on trans women who do sex work, in part because a specific model had been defined for the Lancet publication that Anik showed at the beginning, but definitely we are doing the same thing for MSM and trans women as a larger group in general. So I just wanted to make a few comments. First, just to clarify that I mean the exchange rate between the US dollar and the Peruvian sol is now about 3.25 soles per US dollar. So you can get an idea. The second is that the current price of Truvada commercially sold in pharmacies, and it's sold here in pharmacies, it can be purchased in that way, is about $120 per month per bottle, no? Which is about for about a month. So it's considered high, and definitely some other countries in the region are already offering it at $60 or even $30 per month if it's produced by Gilead. Apparently, it could be purchased at cheaper prices, so it's something that has to be explored, and so there are many things to discuss in terms of ways of accessing this drug. I should also comment that it's likely that the recommendation for PrEP will change from PrEP using Truvada or the combination of tenofovir and emtricitabine to actually either tenofovir alone or potentially with other drugs. So it's also being considered, given that the product itself is not available everywhere, and the difference between the uses of tenofovir alone and tenofovir with the second drug is not is not considered fundamental, essential. Then finally, perhaps one more comment, that the issue of the structural intervention. Definitely, this is not necessarily only about an intervention consisting of a program against stigma and discrimination. It can include components to increase access to this population in various ways, community strengthening components, peer support. So I think that that has to be more broadly discussed, but the cost of that, as they are considered necessary for any kind of intervention, are not included here. And the last point, before getting into any concrete question, is that there's always potentially this tension between a programmatic approach to PrEP, and Anik has essentially described what a national AIDS control strategy could design to actually focus on a very vulnerable population, to invest with a combination of interventions on that population, always with voluntary participation of people, never imposing participation to anybody, but kind of a priority intervention. Whereas other people can consider more of an individually menu-based choice of interventions. So, and that that could be considered an approach fitting particular personal needs. Now, the issue of payment and who would support that, it's something that would need to be discussed as well. Anyway, and those were notes I wanted to make, and I think we have a few comments. Okay, I have Juan Guanira. He asks, assuming that the access to treatment and adherence to trans women, sex workers, and clients is too much optimistic, there's information that trans women have more limited access to care and treatment. That's his comment. Pedro writes, maybe I missed this, but have your group considered 4 doses per day, or 1 before and 2 after of risky exposure, like Molina? I mean, the hypergay study. Are you planning to do that? I mean, in the probably I interpret Pedro's question as if the PrEP on demand regime has ever been considered in the planning or in the estimations here. And he also mentions that injectable PrEP is definitely an urgent need. No, Berta asks if the presentation will be available later, and definitely I respond to you, Berta, that this is being recorded and it's going to be made available in our website and also distributed to those who got registered to participate. Okay, Anik, please.
So I'm gonna do them in order. So the question by Juan, yes, regarding access to care for transgender women sex workers. So yeah, this is, we have assumed that the treatment coverage will increase to 60% if the current guidelines are implemented, and this corresponds to testing every year to every 18 months and to be linked to care. So it is assuming that the system will be functioning better, and it includes the costs for such an improvement. But we are actually revising these costs because there has been a study done for the Global Fund that has estimated the cost of accessing marginalized populations, and specifically MSM and transgender women, and improving the linkage to care and retention services. And so I think that this might probably become more expensive once we include these revisions. But this is basically looking at what could be achieved if we improved access to care, and we're trying our best to assume that, to estimate the cost that this would imply. Regarding the PrEP question, yes, we are assuming daily use of PrEP, and so one of the sensitivity analysis that we could do would be exactly that, looking at alternative regimens such as the one investigated in the hypergay study. So this would result in lower costs. However, it's because none of these studies have included trans, we're not exactly sure if adherence would be as good as it was in this study. So I think we would probably have to assume a lower adherence among trans for these regimens as well, but it would for sure reduce the costs. Regarding the presentation, yes, I believe it will be available later. But as I say, these are preliminary results. We will present this at ISSTDR in about 2 weeks, and I'm producing the new results for that. So I would recommend seeing that one. If I don't know if I think they make them available immediately after the presentation. So you will have the updated results in a couple of weeks.
Okay, I think there was another question from Carlos Laudari, and he asks if there's any difference in cost effectiveness among receptive, insertive, and versatile. I don't know if you have considered, I don't think they have made available differential effectiveness for PrEP according to sexual role. Have they?
I didn't assume different effectiveness of PrEP depending on sexual role. But regarding cost effectiveness, it's likely I haven't looked at the results disaggregated by sexual role, but it's likely that for an intervention like PrEP, it will be more cost effective among those who are mostly receptive, because incidence is higher among those that are mostly receptive. So pretty much any intervention that reduces transmission to the receptive individuals will be more cost effective among these. I haven't looked at it specifically because we're looking at programmatic relevance, and so it would be difficult to actually prioritize an intervention to receptive individuals or insertive individuals because it's very dependent on reporting, and they're difficult to identify, I guess.
Yeah, absolutely true. Now, I would be a bit skeptical about the immediate need to assume that if we're working with trans women, we have to reduce adherence expectations. I think I'm inclined to think that levels observed are not essential to trans women, but are highly dependent on the conditions, the life conditions surrounding them. No, and in many cases, the fact that services are not appropriate, that they have to do other things to survive, really social exclusion. So probably we might have to do studies where if conditions surrounding their lives result in improved adherence not only to PrEP but also to antiretroviral treatment, and this is something much needed. I hope it's been undertaken, because really, I mean, there's no reason to assume that trans women, because they are trans women, they will inherently adhere less to this kind of regimes. Don't you think so?
Yeah, I agree. And one of the interventions that seems to come back quite systematically in the qualitative interviews is the need for health services that are appropriate to their needs. So hormone therapy and body modification, etc. And it's very likely that if this was offered to them in conjunction with HIV services and HIV prevention services, the uptake and the adherence would improve. So these are costs that we will. So this is why we're very interested, I mean, as we've discussed, in doing this analysis, looking at with no additional support and with additional support. And by additional support, I mean all these interventions that would actually improve access to care and uptake from transgender women, and look at how the impact of the intervention is improved, but also looked at how the cost changes when incorporating all of these additional supportive interventions.
Correct. Now, actually, you have considered, what about HIV testing? You have considered that built into PrEP and built into strategies, I mean, the treatment strategies. Where else have you considered testing costs and testing as an activity that is part of a combination prevention package?
Yeah, so it's only included like the screening program as a separate kind of component is only included in the treatment intervention. So in the treatment with new guidelines and test and offer. With PrEP, we assume that there is a cost in outreach and bringing potential users to the clinic, but it's not the same. It's kind of accounted for in a different way than for the increases in treatment coverage.
So testing, the regular testing for PrEP is built into the PrEP activity costs. Then.
Exactly, yes. And for the treatment, it assumes much wider access to testing through mobile clinics. So it kind of assumes a different type of intervention to actually push testing and linkage to care.
Mm-hmm. And okay, there's a comment from Jimena, that it's urgent to consider structural interventions. Various kinds of structural interventions indeed. Now, you had used UNGA's goals. Now we have the 90-90-90 goals. Do you think that will change part of the thresholds we are considering? Should we update those?
Well, I guess this would be included when defining the intervention. So at the moment, for instance, I'm assuming a 60% coverage of HIV-positive transgender women sex workers in the new guidelines scenario, or 80% for the test and offer scenario. And so neither of these actually reaches that 90% coverage that is delineated in the 90-90-90 targets. So one potential scenario would be to look at achieving these 90-90-90 targets and looking at how much this would cost. Mm-hmm. But given that we have tried to keep this as realistic as possible, and so that would kind of imply looking at an aspirational scenario, which I think is always useful, but I think it's important to contrast what we feel is achievable given the current state of services and what we could achieve if they were greatly improved.
Yeah, and actually one last comment is that, condoms have been very important, and now it might be said that we have reached, in some cases, a limit, and it's difficult to move upwards. Part of that might be because of sort of lousy promotion, poor promotion programs, because people got used to them, and there might be some space for a revitalization of condom promotion, although that's always unclear. So that's something to consider. Whereas in this case, PrEP is something new, and it might. The variation of what can be achieved, the potential variation is very broad. It might be very successful. It might not be so. So there's always an element of uncertainty there. But definitely, perhaps there are more possibilities than with condoms, where probably we can't change too much what we're observing now. Don't you think?
Well, I don't know. From the it's always contrasting information in regards to condom, but from all the stakeholder analysis, the information from those qualitative studies suggested that the current condom promotion in Lima, or in Peru, or at least in Lima, was really suboptimal. So that the condoms that are distributed from the Ministry of Health are considered, are stigmatizing because because they're of low quality, and that there is problems in stock, so that
Right.
We don't seem to receive enough, or at least it's not a constant kind of provision of condoms. So from that feedback, it would seem that the current condom promotion strategies are suboptimal, and so this is why we believe that it could actually result in an improvement if there was much stronger promotion of condoms with campaigns, not only with distribution of condoms.
Right. Yeah, new branding, a new way of promoting condoms, definitely. Okay, well, I think we are already at the end of our hour, and we really thank you very much, Anik. I think it was a very interesting presentation, particularly for people who are trying to think how PrEP could fit within combination prevention programs, and shows the utility of mathematical modeling to do this and consider synergies in effectiveness and also cost effectiveness. So thank you very much, and we'll see the progress of this. As you say, it's going to be presented in the Brisbane conference in Australia in 2 weeks, and then we hope to publish it. Okay, so thanks again, and I end by restating that this presentation has been recorded and is going to be uploaded and distributed very soon, in the next, either today, later today or tomorrow, and that next Tuesday, 5 days, no, Tuesday the 8th of September, we have a new webinar with Dr. Fabio Mesquita, the director of the National AIDS Control Program of Brazil, and he was a plenary presenter at the Vancouver AIDS Conference. He presented on PrEP, and he will be sharing with us his presentation this coming Tuesday at the same time. So thanks to all, thank you very much, and see you soon.
Thank you.
Bye. Thank you, bye.